Good morning, everybody. We're just going to give about another minute or so and we'll go ahead and get started. Okay, good morning, everybody. Thank you for joining us this morning. My name is Catrice Nakamura. I am the director of the Neuroscience and Stroke Program at Little Company of Mary, Torrance, and San Pedro. Again, thank you for joining us. We have two excellent physician experts who are really experts in their field in Parkinson's disease and movement disorders. But before we get started, I want to go over a couple of housekeeping issues. This is going to be a 45-minute lecture for both of our speakers combined. We're going to take our questions at the end, and I want to point out on the top right of your screen, you'll see a little bubble with a question mark, and that is our, that's where you can kind of go in there, click that, and then you'll see a field where you can go ahead and type in your questions there. Feel free to type them in as the lectures are going, and we will capture those at the end of both of our lectures. So let's go ahead and get started. I'm going to get ready to introduce our first speaker. Our first speaker is Dr. Natalie Diaz. She is a board-certified neurologist with fellowship training in movement disorders. Her clinical practice focuses on the evaluation and management of patients with Parkinson's disease, atypical Parkinsonian disorders, Huntington disease, and other core form disorders. She also has specialized training in the evaluation and programming of deep brain stimulation as a treatment for Parkinson's disease, essential tremor, and dystonia, as well as the therapeutic administration of botulism toxin injections for non-cosmetic indications. Welcome, Dr. Diaz.
Thank you very much, Catrice, and welcome everybody. It's so nice to see such a great turnout for today's presentation. So this is a little bit repetitive, but for those of you that don't know me, I am a movement disorder specialist, a neurologist with specialized training in movement disorders, and I joined the Pacific Neuroscience Institute here at Little Company of Mary a year ago now in October. And in addition to seeing patients here in the clinic for the last 15 years, for the last decade or so, I've also been a clinical trials researcher, mainly in the area of Parkinson's disease, trying to move the needle forward in movement disorders, and been an investigator on some of the most recent available medications in Parkinson's disease. I do not receive any money from drug companies or device companies, so I do not get paid to speak for any company or any product. Do not receive any consulting fees or honorariums. So this presentation is coming to you free from any financial bias. So we're going to be talking today about essential tremor and Parkinson's disease. These are the two most common conditions we see in our clinics. Essential tremor being the most common disorder. It affects roughly about 10 million people in this country and can happen at any age, most commonly over the age of 40. And it's considered mainly a tremor disorder that progresses over time and used to be thought to be benign, but in people that have it can cause sometimes disability and lower their quality of life. Parkinson's disease, on the other hand, is considered a degenerative condition of the nervous system. The brain and the nervous system can also affect at any age, but most commonly presents after the age of 60. Much less common than essential tremor, almost a tenth as common, so about 1.5 million people in this country. And they can have not only tremor, but a spectrum of other physical and non-physical symptoms, what we call motor and non-motor symptoms that can affect their quality of life. So let's focus on essential tremor. This is a neurological condition where there is tremor of the hands and the arms on both sides of the body. This is the type of tremor that occurs while you're in motion and can affect your daily activities, such as bringing a spoon or fork to your mouth, bringing a cup to your mouth, can affect your writing, putting on makeup, getting dressed, using a computer. And with time, this tremor can become worse over time and may cause disability. About a third of people can also have a head tremor, what we call a no-no tremor, or a yes-yes tremor, depending on the direction of the tremor. And about 10% of people, it can affect their voice. Very classic being Katharine Hepburn. She had a tremulous voice, if anybody remembers who she was. And these patients can also sometimes have some other mild features like problems with walking and balance. They can get a rotation of the neck, especially in people that have head tremor, what we call cervical dystonia or torticollis. They can also have some mild memory problems, but these are minor, and usually the tremor greatly outshadows these symptoms. We don't really know yet what causes essential tremor. We think that advancing age probably plays a role as it's more common as people get older. There probably is a very strong genetic component, as a lot of people with tremors say that they have other family members that also have the same condition. And unlike Parkinson's disease, we don't have any specific pathology that we see in the brain. There has been accumulating evidence over the decades that the connections between a part of the brain called the cerebellum in the back and the deeper part of the brain called the brainstem, that there may be abnormal connections and abnormal brain waves or oscillations that occur in those areas. Because we don't really know what causes it, there's no specific test for us to diagnose it. It's largely a diagnosis of exclusion. So when people come into the clinic, we have them do activities like write for us. We have them do these spirals that we call Archimedes spirals to kind of bring out the tremor. We have them drink. We have them do different activities. We look for other potential clues like family history or response to alcohol, which sometimes seems to help the tremor. And then we exclude other things that sometimes can produce tremor, such as if they're having too much caffeine in their diet, or they're on a list of medications that can sometimes cause tremor. We look for dysfunction in certain organ systems, so we'll do blood work for thyroid, liver, and kidney dysfunction. And sometimes Parkinson's disease can be confused for essential tremor, especially in the early years in some people that have a lot of tremor. Now, in the majority of people, we have no problem distinguishing these conditions, but in some people early in the disease, they can have a lot of tremor. This is where we have a scan that's called a DAT scan or a brain SPECT scan. Basically, it's a functional imaging scan that uses a specific isotope that we give intravenously, and it tags cells in the brain that produce dopamine, which is low in Parkinson's disease. So if you can see here, if you have Parkinson's disease, you'll have a low level of dopamine in the brain, whereas somebody that has essential tremor or doesn't have Parkinson's disease, they have this nice normal comma-shaped. Usually the radiologist looks at this and makes a call qualitatively. There is also a software that's available that measures this objectively and then compares it to a database of people that don't have Parkinson's disease of different ages and gives us an objective measurement comparing it to somebody who doesn't have Parkinson's disease. And it gives us another level of security. Little Company of Mary is one of the local institutions that does have this software, but it's not available everywhere. So once we're pretty certain that we're dealing with essential tremor, there are a number of medications that are available. I will start by saying that because we don't know what causes tremor, these are all very nonspecific medications that basically dampen down brain activity, and because of that can have a lot of side effects, can make people feel sleepy, foggy in their thinking, can make confusion worse, can cause problems with low blood pressure. And tremor is a very difficult symptom that sometimes we just can't control with medications. And our goal really is just to try to reduce the tremor with some of the better medications. What we have here are first-line therapies by about 50% so people can function. I won't go into too much detail, only knowing that propranolol is the only one that is FDA approved. The rest are what we call off-label, but there is good evidence that they can help in tremor. And which one we choose depends really on the person, how old they are, what other medical conditions they have, and how they might respond to some of these medicines. Besides medicines, there are a variety of aids and devices that are available. I won't go into too much detail. There is a website that I'll put up at the end. The Essential Tremor Foundation has a list of all the devices and aids that are available. Some of them have some insurance coverage, but some of them are just pay on your own. And they can be anything from weights that you put on writing and eating utensils, weighted cups with lids. There's vibrating utensils. There's apparel like magnetic buttons that just snap shut, and software that helps cancel out tremor or just use your voice. There's a variety of wearable devices that you put on your wrist or your hand that try to dampen down the tremor or vibrate or stimulate nerves in the wrist and temporarily can cancel. And, you know, we talk about these and some people like them and some people they do nothing for. They can be expensive. And so it's always something to explore with your insurance. So when we have somebody, we're pretty sure it's essential tremor and we've tried medicines or their medicines just give them intolerable side effects. We do have some surgical treatments that can be very useful. Deep brain stimulation has been around for more than 20 years, and Dr. Langevin will talk a little bit more about the procedure. Studies have shown that in the hands of a good neurosurgeon, people can get upwards, you know, close to 90% improvement of tremor, and some people get complete resolution of tremor. The advantages of deep brain stimulation is that it can be done on both sides. And it is also adjustable. So over time, if the tremor gets worse, the settings of the DBS can be adjusted. It is also reversible. So if people don't do well with it or they have side effects, the system can be removed. Outside of DBS, over in the last 5 years, we've had the new MRI-guided focused ultrasound. This does not involve anesthesia or surgery. It involves using MRI to guide high beam focused ultrasound through the skull and into the brain, into a certain area of the brain where it creates a lot of heat and creates a lesion in the brain. Also can be very effective, sometimes complete resolution of the tremor. The only disadvantage is to this is that right now it's only approved for one side, so people have to decide which side they want to have the treatment on. And although they claim that it's completely non-invasive, it is a procedure where you are creating a lesion in the brain. You're creating a hole in the brain, basically burning a hole. So it can have its potential side effects and risks as well. Usually people that are on anticoagulants or have severe kidney disease or have pacemakers are not candidates for this type of therapy. So I'm going to switch gears a little bit and I'm going to talk now about Parkinson's disease. And as I mentioned, we consider this a degenerative brain syndrome where groups of cells kind of degenerate over the years and we get accumulation of abnormal proteins, what we call Lewy bodies, in those areas that degenerate. We don't quite know why those processes happen, but this is clinical pathology that we see. And with those changes in the brain, people get loss of certain chemicals, the most important one being dopamine, that leads to a lot of the physical symptoms that people get in Parkinson's disease. So tremor is something that people can definitely have. It's different than the typical essential tremor, usually affects one side only or more on one side, usually does not interfere with activities like I mentioned with essential tremor. But when people are sitting and watching TV, they'll feel a hand or a leg shake. Sometimes maybe when they're holding a coffee cup or a newspaper, or when they walk, their hand might shake. So we can distinguish the different types of tremor. Their muscles may get stiff, their movements may slow down so that their posture changes, their walking becomes slow and shuffled. They may lose expression of their face or their voice may become softer. Their handwriting does not become tremulous usually, but rather becomes small and difficult to read. And then they can have also balance problems. In addition to this, there's a lot of other non-physical symptoms that I won't go into that also are part of this: memory and thinking disorders, mood disorders, acting out of dreams, constipation, fluctuations in blood pressure. And we take a look at all of these to help us make the diagnosis. And when there's any doubt with essential tremor, if somebody has a lot of tremor, that's when we use that DAT scan. There's an arsenal of medications that we use with Parkinson's disease. At last count, there's about 20 approved medications, and they run the gamut from medications that try to boost your own brain dopamine, what we call the classic levodopa and all its formulations, the newest one being the inhaled levodopa when they need it, when the medications wear out. There are dopamine agonists that try to act like dopamine. The newest one that just came out this year is Kenmobi. It's a little strip that you put under your mouth that kicks in pretty quickly and keeps people going for about an hour if their medications wear out when they're out and about. We have medications that enhance the effect of levodopa. Ongentys just recently came out. It's in the same family of medications of entacapone. It boosts levodopa and dopamine in your brain and makes it last longer. Then we have a variety of medications that work on other brain chemicals. The Gocovri is a newer formulation of amantadine that's taken once a day. And istradifylline is a medication that is alone in its class, that's been around in Japan now for almost a decade and just approved here in the last couple of years. And it's for people whose medication effect doesn't last long enough throughout the day. Now, we can keep people going on these medications for a long time with Parkinson's disease and moving and doing all the things that they want to do. But invariably, most people 5 or 10 years into this condition start to develop what are called motor complications. And there's a myth out there that it's purely just the medications that bring this on. And so I see a lot of people that hold off taking medications for a long time because of fear of these. And truly, this is a combination of what's happening in people's brains, so the low level of dopamine, and then the replacement with these drugs that are not perfect. And so it's not just the medication, but it's the replacement that is the combination of the two. So many times, even if people avoid taking these medications, we still get these. And motor complications include things like the medications just don't last long enough and we start to bring them closer together, or we add enhancers. They can include involuntary movements, like if anybody's seen Michael J. Fox, the dancing, wiggly movements that occur when the medication is working. And then unfortunately, we have a group of symptoms that over the years just become unresponsive to the medications, also don't respond to surgery. They tend to be what we call midline symptoms, problems with swallowing, problems with balance, and problems with freezing when you walk. We think these probably don't have to do with dopamine at all. They probably come from a different part of the brain, and that's why they don't respond to a lot of the therapies that we have. So when people get into this stage and they start developing fluctuations and these movements, and they are, starting to have problems with these, and they're, reasonably healthy enough that surgery may be an option, this is where we start discussing surgery and the options that people have available, just so they start thinking about. Again, deep brain stimulation has been around for a long time in Parkinson's disease, almost 20 years. It can be a very good therapy, and studies have shown that, again, in the hands of a good neurosurgeon, people can have good control of their symptoms for 15 years or longer. That doesn't mean that people don't take medication. So from an expectation standpoint, I always tell people this isn't a cure and won't get you off medications. But if somebody's having these ups and downs, or they can't tolerate side effects of medications, what it does is it tries to smooth the effect so people don't have the ups and downs that they get with the medicine. It's not a therapy that's good for everybody. So here is, who I think is a good candidate. So somebody who's, reasonably healthy enough that can withstand anesthesia and surgery, somebody who we feel truly does have a diagnosis of Parkinson's. So that's why it's always important to see a specialist if you're considering DBS. somebody who's had it for a few years, there are a few conditions that sometimes are Parkinson's-like that can be confused for Parkinson's, and 4 years usually gives us enough time to weed those people out that don't have Parkinson's disease and therefore won't respond to this therapy. People that have a good response to levodopa. So generally, if you've tried dopamine-based drugs in really good doses, really give them a try, and you've never had good response to levodopa, you're not going to generally have a good response to that to surgery. And we use that as a good indicator as how people will do. We generally try to do some testing so that there aren't any major mood or memory, thinking, cognitive issues, because those sometimes can get worse with the surgery. And like I said, we can get reasonably good control for more than 15 years. It is adjustable, so as time progresses and symptoms progress, we can get good control of symptoms over the years. If people just don't like the idea of brain surgery or for some reason are not good candidates for anesthesia or surgery, the other option that we have available when people are in that fluctuation stage is something that's called Duopa. It's been around for more than 20 years in Europe and Scandinavia. It's been approved here in this country since 2015. This is levodopa like the Cinemet and other formulations that people take, except it's in a liquid gel formulation that's infused through a surgically implanted little tube through the skin into the small intestine, and it continuously feeds levodopa into the system. The advantages is there's no anesthesia, no generalized anesthesia, no intensive surgery. Those people that are not surgical candidates and this is a reasonably safe procedure that they can go through. If somebody has memory or thinking problems, or mood things that prevent them from having deep brain stimulation, this is a good one. And also long-term efficacy has been shown, up to 20 years now with Duodopa and those people that were in the studies in Europe and Scandinavia. So that's my talk. Here's a couple of important resources. If you have one of these two conditions, the International Sessional Tremor Foundation has a lot of resources of some of the things that I've talked about. And be careful what you read about on the internet. There is a lot of good information, but there's also a lot of misinformation, and not everything that you read that's true pertains to everybody. So if you're looking for credible, good websites, the national nonprofit organizations, we are an American Parkinson's Disease Association center, so we do work with them. But the Parkinson's Foundation and the Michael J. Fox Foundation are also great resources, both for learning more about it, for caregiver resources, as well as for what clinical trials are available for these conditions. Thank you.
Thank you, Dr. Diaz. That was a lot of great information for our attendees. I just want to remind everybody that we are going to do questions. So if you do have any questions for Dr. Diaz, you can go ahead and write them in the Q&A box, and we will address them at the end of our next speaker's lecture. But go ahead and do them so you don't forget them. That's what I always encourage people to do. So I'm going to go ahead and introduce our next speaker, Dr. Jean-Philippe Langevin. Dr. Langevin is a board-certified and fellowship-trained neurosurgeon specializing in the surgical treatment of movement disorders, epilepsy, and psychiatric conditions. He has extensive experience using neuromodulation to treat conditions such as Parkinson's disease, essential tremor, dystonia, epilepsy, and obsessive-compulsive disorder. He employs a variety of treatment modalities, including deep brain stimulation, vagal nerve stimulation, and interstitial laser ablation. He is a director of the Restorative Neurosurgery and Deep Brain Stimulation Program at Pacific Movement Disorder Center. Welcome, Dr. Langevin.
Thank you, Catrice, and thank you everyone for joining this morning on a Saturday. I just wanted to briefly mention, so Dr. Diaz and I are both part of the Pacific Neuroscience Institute. We obviously work at Providence, a little company of Mary. And just to give an overview, background information, I joined the practice a number of years ago to offer DBS surgery, and it started at Santa Monica at St. John's Hospital. And what prompted us to really branch out and offer the care at Little Company Mary in Torrance is because we did a lot of talks at support group, as well as participation in movement disorder programs like offered by the APDA and other associations. And in speaking with the patients, what came up over and over when we were asking patients, what they were looking for in a specialized movement disorder practice, one thing that came up was really the proximity of the physician. And, to us, it was very compelling and made a lot of sense because, you have movement disorder, it's already difficult to get around. And so it makes a lot of sense that your physician is close by to where you live so that you have easy access and you feel more secure. And certainly, that becomes even more important in the context of surgery because, it's difficult to have surgery where the hospital is further away from your home so that the family has difficulty reaching you. And if there are issues, it's reassuring if you're close to your physician so that they get promptly looked at and corrected. And so that was the main driver, and we started here the program already 3 or 4 years ago, and things have gone well. So the purpose of my lecture today is to talk about the way we perform the procedure over at Little Company Mary in Torrance, and to go over some of the new advances as well in our field, because the last, I'd say, 5 years, I've seen a lot of progress. So these are the objectives. So just to put everybody on the same page as to what DBS is, and go over some of the indications briefly, since Dr. Diaz has gone over them to some extent already. And finally, the surgical technique. And the purpose is to demystify a little bit the surgery so that everybody understands what it's all about. And so this slide shows briefly an overview what DBS is. Essentially, it's oftentimes a pacemaker for the brain, but essentially it's to electrically stimulate a very small and precise regions of the brain. And so we see it here on this depiction right in the center. And in order to do that, the electrode is connected to a wire. And note, importantly, that the entire system is under the skin so that there are no components that are showing up on the outside. And then there's typically a pulse generator that's located under the collarbone, also under the skin. And so I just want to give a brief overview of the 3 different companies that are available currently commercially on the market in the United States. And that's where we've seen a lot of progress, a lot of change, I'd say, over the last 5 years. And one of the things that probably is the most important that we've seen is that all the devices now have some MRI compatibility. So when we started in the field a number of years ago, it became impossible for patients to have an MRI after the placement of the device. And so that's a problem where, people would get a DBS and then have a hip problem or a back problem or some other health issue that needs to be followed up with magnetic resonance, and it was just not possible to get the study. So just in the last couple of years now, all the vendors have finally reached agreements with the FDA to get some form of clearance. It still requires to go to a hospital where protocols are in place to safely perform the MRI, and so we have that at our center, obviously in Torrance. So this is the first device. Medtronic was the only company that was available on the market for a number of years, but just recently in July, their device has been upgraded now to this system called Percept. And the 3 components are the electrode that is located inside the brain. So you see the 4 ring contacts at the tip of the electrode. And the small electrical field can be shaped in a combination or around any single electrode contact. The patients are provided with this Samsung device that looks like a Samsung Galaxy cell phone. And note that what you can do with that device as a patient is you can check your battery if it's fully charged, or if it's in need of replacement, if the therapy is on or off. And so this is the second window here where with the help of your physician, you can then create different groups once the device is in. So for instance, in this patient, there's a group for when the patient is talking, when he or she is walking. And so it's basically a therapy that modulates throughout the day. So it's not something that's static. It's a therapy where you can adjust the level of stimulation throughout the day if you wish to do so. And finally, with the Medtronic device, it's essentially a bidirectional system now where not only are we placing electricity in a small area of the brain, but we are also recording the activity inside the brain. And so in an effort to do that, we can create a series of events where when the patient is taking medication, they can click on this button. When they're performing exercise, they can click on this button. When they're having symptoms, there's another button. And so essentially it's an electronic diary of things that you're doing throughout your day, symptoms when you're having a hard time. And when you meet your physician at follow-up appointments, it's a diary that you can go over. And oftentimes that's going to allow to make adjustment either in medications or in the DBS system to improve the therapy. St. Jude, now acquired by Abbott Medical, have this device, as you can see, very similar components. You have the intracranial electrode, then you have the pulse generator that's located under the clavicle or the collarbone. You have this Apple iPhone product that the patient is receiving, giving the similar information to the patient. And finally, the physician is programming your device using an iPad. And so this is how it looks like. And one of the difference between Abbott and Medtronic is that the physician with the two middle contacts can break down and shape the electrical field slightly more precisely around the electrode tip, where they can push the electricity more to the left or more to the right side in an effort to avoid perhaps some side effects or to reduce the amount of electricity that's needed to perform the same benefits so that your battery lasts longer. Another player is the Boston Scientific System. So that's the last company also on the market. And a very similar as Abbott, has two contacts in the center that are broken down into 3 subunits to modulate or to send the electricity more on one side versus the other. So that's one of the other great advances in the technology that we have currently. In this scenario, the patient is provided with this patient interface here that looks like a remote control, but essentially gives you the same information about the status of your device, the ability to turn it on or off, to turn it up or down. So this is the picture of the implantable generator. And finally, the physician is using this tablet from Microsoft basically in the background. So very similar setup in all companies. But there are a few things to keep in mind as a patient when you decide to have the brain stimulation. And oftentimes I tell patients that, the most important thing is to have a conversation with your physician, and in particular the neurologist who will program the device after the surgery. But some of these things to keep in mind, so MRI compatibility used to be one, but now all 3 companies are MRI compatible, so that's less of an issue. However, there's still an importance to consider the directionality or like the precision at which the electricity needs to be delivered. So some devices offer the ability to shape the electrical field slightly more than other devices. Another thing to discuss is perhaps in your case, it's important to keep an electronic diary, in which case perhaps the Medtronic system would be a good idea. And your social situation. So if you're planning on moving or going to remote areas, so perhaps certain companies have coverage where a physician is going to be readily available to program the device, whereas other regions will have essentially a readily available physicians to control all three devices. So I think all three devices are exceptional. There've been certainly a great amount of improvements over the last 5 years. Those implants are highly reliable with very rare and sparse recall from the FDA and no major problems related to the implant and the compatibility in the human body. However, there's some subtlety that are important to consider, when you select one device over another. On this slide, it's just a depiction to show a little bit more of that concept of directionality or shaping of electrical current. So you can see here on more traditional type of stimulation, where, as I mentioned, the physicians can select any of the 4 contacts that you can see here as a ring. In this case, the physician has elected to stimulate the bottom contact. And what they can do is a circle. So that's the electricity around that contact. And the thing that can be modulated here is the size of this circle. In the newer device that offer directionality, you can see that now you're not bound to simply a circle. You can shape the electricity skewed on one side versus another. And in the brain, this is how it looks like, where you have the electrode implanted in the intended target, in this case the STN, which is a common target for Parkinson's disease. And in the case of a traditional stimulation, there could be a slight encroachment or surrounding area that can limit how much intensity or how much electricity you can deliver to the target. Whereas with a more directional current lead, the electricity can be shaped so that you spare that other area, and then you can move more of the current inside the intended target. So that's one of the advantage of certain companies. So I covered this issue. And so this video here is in an effort to bring it up to life as to what it means. Why are we going through the steps of surgery, taking those risks, and how does it improve quality of life? And so, here's a patient with Parkinson's disease preoperatively, and you can see how there's a lot of stiffness and a lot of slowness to some extent in the movement, trying to get out of the car to go to, for example, here a physician's appointment. The same patient post-operatively walking with the help of a physical therapist, and you can see how there's more fluidity of the movement, essentially. So the idea is that Parkinson's disease improves the quality of life by improving all the cardinal symptoms of Parkinson's disease, namely the bradykinesia, the stiffness, and the tremor. So who should consider having DBS? Essentially, as Dr. Diaz mentioned, so ideally someone who has been suffering from Parkinson's disease for about 3 to 5 years, just has to make sure that the diagnosis is well established, that the patient is not suffering from a condition that could mimic Parkinson's disease. Ideally, someone with moderate severity. And that means that it's better to not wait until you have stopped performing the hobbies or the activities that you enjoy throughout the day, because what the studies have shown is if you wait until you have stopped doing those activities, even if you benefit from the surgery, it's hard to regain access to those activities once you've stopped. So it's generally recommended when you start having a lot of difficulties performing at work, or you're considering stopping the hobbies that you care about, to then consider having DBS at that time so that you can pursue those activities without stopping them first. Patients with great response to Sinemet or levodopa or other Parkinson's disease medications tend to also do better with DBS, where the medication therapy is acting as a predictor of DBS response. In this graph, essentially just shows a little bit with the peaks and troughs that people are going through throughout the day with Parkinson's disease and taking medications. So in this case here, the patient starts the day, they're having a little bit more symptoms. They take a dose of levodopa here where you see the arrow, and their motor improvement increases. So they're feeling very well, very fluid, and then there's a slight decline. But they are still in a well-controlled zone. So although the symptoms are slightly fluctuating throughout the day, there's no impediment to their activity. In a poorly controlled case, the patient goes from being frozen or having a lot of difficulty performing the activity quickly to a very well-controlled zone, but overshoots to those dyskinesia, so the release of additional movement, as Dr. Diaz mentioned, like Michael J. Fox, for instance, and then an abrupt drop as the medication is wearing off. And so then there's rapid cycles throughout the day. And so those are excellent candidates to DBS because the therapy is continuously on in the background and acts as a sort of an equalizer to bring you back into the well-controlled zone. So it allows to cut off those peaks and cut down also those troughs and to help your neurologist manage your medications so that we return from a poor control situation to a good control situation, and that allows to perform more activity. This is a complicated slide, but just here at the red arrow, when they looked at patients across the United States where they maintain a diary of their activity between good control and poor control throughout the day, they noticed that with DBS you gain about 4.5 hours of useful time. The symptoms that are typically not improved with DBS are the ones of the midline, as Dr. Diaz mentioned, are more difficult to control with Parkinson's disease, such as difficulty swallowing and gait freezing. Again, those are some of the quality of life improvements. So people returning to some of the activities that they enjoy, such as skiing in this case, or swimming and surfing, because they're not as afraid that the medication is going to wear off during the course of their activity. So for the control of tremor, essential tremor, so I have this video to show with DBS off, and you'll see here on the right side, patient turning on the device. Let me just pause this side here so I can synchronize a little bit more. But same patient taking on the same day with the DBS on, DBS off, and so we can see him going through some of the physical examination step. So oftentimes the patients report that they are unable to complete very basic tasks such as signing checks, signing their name because of the tremor. And in this case, the medication oftentimes only have marginal response and improvement, but the DBS can offer a very dramatic improvement. So I'm just going to pause here. So just to show here a little bit the difference once on the right side we're completed. And so you can see, and oftentimes patients will tell us that they haven't seen themselves, with the legible writing for many years. Drinking is a very common problem as well, where there's a lot of spillage, and patients tell us that they're not going to a restaurant as a result of that. And as you can see, the DBS transforms that problem and improves the tremor significantly, that they can return to those activities. So how we perform the surgery here at the Little Company Mary. So we have moved from using a frame-based approach, as we see here on the right side with a large metallic device around the head, to a custom-made frameless device that you see here on the left side. And the way we perform this surgery is in a few steps. So first, patients come into our clinic. So a few weeks prior to the definitive surgery, we And during this time, we're going to place small markers on the skull. And so this is done simply in our clinic. And then we made a tiny opening on the scalp where the marker is implanted. So the marker is a few millimeters in size under the skin. And following this small procedure, the patients return home. And during that time, we plan the entire surgery, which means that we look at the MRI of the patient that you see here on the left-hand side. We determine the trajectory for our electrodes. And the computer software determines the shape of this custom-made device here that's going to fit all 4 markers for that specific patients. And once the device is installed on those markers, it guides the electrode along the intended trajectory. During the surgery, we make a small opening on the scalp on both sides, and this is done under anesthesia, so the patient is asleep at that point. And then the electrode is guided in place with this device. As I said, it attaches to a custom-made frame. And as you can tell, our patient is not, the head is not fixated to the bed, so the patient can freely move during the surgery, which is more comfortable for the patient. And we can place both electrodes simultaneously. And what we like to perform is an exam during the procedure. So as you can tell here, the patient is awake. Dr. Diaz or one of our nurse practitioners performs an examination very similar to the clinic to check the tremor, to check how responsive the patient is from the stimulation. At that point in time, the electrodes are connected to an external generator that mimics the final product once the pulse generator is in place. And so that helps us predict if the therapy is going to be beneficial with the electrode in that specific location. And it helps us predict as well which stimulation contact we should be using post-operatively. And so this is the part of the surgery where, you know, it's very useful to have this frameless device. As you can tell, it's not impeding the movement of the patient, and the discomfort from the surgery is minimal. A lot of patients ask me how the electrodes are fixated or secured in place on the skull. So the manufacturers have this small cap device that essentially locks the electrode in place, and it's recessed into the bone slightly so that there's no components that are showing, so no profile showing from the outside on the scalp. But essentially, once this is locked in place, the electrode cannot move around. And this is the end of the stage of the major surgery. The patients stay in the hospital for about 1 or 2 days following this procedure. The electrode, again, are located in that precise spot inside the brain and tunneled underneath the skin, typically behind the right ear. So this is all behind, under the skin, essentially. And then 1 week later, the patient returns, and under general anesthesia, we place this small pulse generator under the collarbone. We retrieve the tip of our electrodes, and then they are connecting to a connecting wire. So a lot of people ask me how we get from one spot to another. So we have this device here provided by the manufacturer again that allows us to create a path for the connecting wires from one spot to the other under the skin. And finally, you have the completed system where the electrodes are in place and connected to the generator. And at that point, the physicians can then use the tablet to program the device. These are the different types of electrodes. So a more traditional electrode with the 4 contacts that are rings, whereas perhaps newer advanced in electrode shape offer a sub-units of the 2 middle electrodes that are broken down into 3 subunits. Steps after the surgery, so just briefly to leave some time for questions. Essentially what we look for is continuing the medication since the system is not on for the first few weeks after the procedure. And we emphasize a multidisciplinary approach in our hospital to provide early ambulation, so to favor a early return to normal activity, basically. So we continue all the Parkinson medications in collaboration with our inpatient pharmacy to make sure that the patient is receiving all their meds on time. And then we work with our nursing staff and our physical therapists to make sure that our patients are not frozen after the surgery and return to normal activity quickly. And the frameless device allows us to reduce the amount of anesthesia that is provided during the surgery so that there's a faster return to normal activity. And typically our patients return home about 1 or 2 days following the procedure. In conclusion, the DBS is a good option for patients suffering from essential tremor or Parkinson's disease patients in the moderate stage and who have good response with medications, but perhaps where the medication is not sufficient anymore to keep them in their activities, including their job or hobbies. So on that, I just want to thank everybody again, and this is our phone number, both to reach me and Dr. Diaz.
Great, thank you, Dr. Langevin. Thank you for that great overview on surgical approaches to treatment of DBS and treatment of Parkinson's and essential tremor. Great to see the impact on quality of life and really the details of the surgical approaches. I want to just take this time now to kind of flip back. We're going to go back to Dr. Diaz and some questions that came up on our Q&A box for Dr. Diaz and get through these questions. We got a good just about 6 minutes, 7 minutes or so to get through some of these questions. The first question I see here is, Dr. Diaz, can you tell us the difference between familial tremors and essential tremors?
Right, so they're one and the same. So essential tremor is considered a familial tremor disorder. It has a very strong component of genetics, so that, you know, a good number of people, we say more than half of people that have essential tremor have other first-degree relatives that have tremor, parents, grandparents, you know, other close relatives. May not always have the diagnosis, they may have lived with it for years, but people can remember relatives that have, you know, they shake when they, you know, carried their cup of coffee or ate or whatsoever. So there are other types of familial tremors, but those are usually along with other symptoms, whether they can be seizures or they can be cognitive impairment. So there are other genetic disorders where people can have tremor and other neurological symptoms that together run in the family. But essential tremor is the most common cause of familial tremors.
Great, thank you. I have a couple of medication questions that have come up. Let's see, one is for Parkinson's, what's the difference or the pros and cons between increasing levodopa versus adding newer extender drugs?
Right, so that's a good question because, and it depends on the person, how they're doing, right? So when somebody comes into the clinic and they're several years into the condition, there's a couple of key questions that we ask. One, if they're on levodopa or Sinemet formulations. One is, when you take your medicine, you know, an hour or two, how good is the effect? Do you feel like with that medicine, you feel good and you can move around and do the things you need to do? And then if the answer is yes, then the next question is, well, does the effect last between the doses, right? So if people tell me that, well, I take it and I feel better, but I don't feel great, and the medication wears off, then I might give them more levodopa to increase the amount of levodopa that they're getting in their system. If they tell me that the levodopa works, hey, I feel great, I can get up and move around and do the things that I need to do, maybe even have a little bit of these extra movements, the dyskinesias, and that's a sign that really we shouldn't push it too much. So they get good effect, but the effect wears off after about 3-4 hours or something like that. That's when we add the enhancers, right? So they get good effect, but we need it to last long enough. that's where the enhancers come in. Sometimes the enhancers can be so good that they boost the effect of levodopa, and we got to pull the levodopa a little bit. So that's generally how we think about when to increase levodopa or when to add an enhancer.
Okay, I have one more medication question, and it's I've been on, and I'll probably butcher this, but lamotrigine for 4 years, and I noticed that it was not on your drug list. Is this one of those newer type of drugs, or perhaps an older one?
Yeah, lamotrigine is not one that we typically use for tremor, right? There's been a number of medications that have been looked at for tremor, and a good 2 or 3 medications that were on that list that I showed you for essential tremor are actually approved for epilepsy, and have a dual use that we use them for tremor, and have decent evidence for tremor. Lamotrigine is another one that's an anti-seizure medication, and people have looked at it in tremor. None of the studies have really shown a significant effect, and I don't really use it, and I like to say most movement disorder neurologists don't really use lamotrigine.
Thank you. I'll take this last one, and then we'll ask Dr. Langevin some questions. This one is, I've had occasional trouble swallowing where it feels like food is getting stuck for like 5 or 10 seconds. Is this maybe a symptom of Parkinson's? My dad had PSP, and my sister has just been diagnosed with Parkinson's and ET. Is that something this person should be concerned about?
This patient should definitely see a neurologist and maybe see a movement disorder specialist. There can be many reasons why people have problems with swallowing. So just because they have a family history doesn't necessarily mean that they have the same condition, although problem swallowing can be part of those conditions. So seeing a neurologist and especially a specialist would be good to see if there's any other symptoms or signs there that would point us in that direction. There can be a lot of causes for swallowing problems, and so many times we'll send people to a speech and swallow therapist so they can do some testing and see if there is a problem motor control of swallowing before we start worrying about it. Because sometimes it can be, people with long-standing reflux can start having problems with swallowing. People can have other sort of anatomical problems. Sometimes if there's a lot of anxiety, people can feel like they're having swallowing problems. So we start first just to take a good look and see truly if there's mechanical problems with the swallowing, and then a specialist to see if there's any other neurological signs and symptoms that would push us in the same direction as what the family has.
Great, thank you so much, Dr. Diaz. I have a couple questions here about the neurosurgical perspective. So I'd like to switch over to Dr. Langevin and ask him these questions. The first one is, does medication reduce or eliminate once DBS has been initiated?
So that's a great question, and one that comes up oftentimes. So depending on the conditions, right? So oftentimes in the case of essential tremor, the medications are marginally effective for those patients who come to our attention. So oftentimes for those patients, they will stop, their medications after the surgery because the benefits of DBS far exceeds that of the medications. In the case of Parkinson's disease, it's different. So certainly the patients are expected to continue on their medication. So as I mentioned a little bit in my presentation, so we see DBS sort of as a equalizer in the background where the stimulation is always on. And so it helps you to bridge from dose to dose. Oftentimes it will allow your provider to reduce the dosage or to reduce the frequency at which you're taking the medication because of that action. But it's not something where we expect patients to be off meds. So a good rule of thumb is that you may expect about 20 to 30% reduction, either in dosage or frequency.
Okay, great. I have another one. It's about, okay, so what is your opinion on the Cala Trio device that is advertised for essential tremor?
Yeah, so for me, my experience with the device is more limited. So perhaps Dr. Diaz has more information, but it's one of those external device that, similar to those specialized utensils, may help out in the case of essential tremor. But maybe Dr. Diaz has some additional information.
Yeah, I have a number of patients that use it. In fact, our group in Santa Monica, our Pacific Neuroscience group in Santa Monica, was involved in the trials of the Cala Trio device. It is a wrist-worn device that stimulates two nerves that travel through the wrist. It gives a frequency there that tries to cancel out the tremor. And the studies that they did on it showed that it can reduce tremor, usually not completely eliminate it, but reduce it. And the effect will last anywhere from 1 to 2 hours. So it's not a long-lasting relief, but sometimes people can wear it, multiple times a day, especially if they work or they have, activities that they really need a reduction in tremor for a period of time. They will use it so they can write or use the computer at work for a couple of hours, maybe try it in the morning, try it in the afternoon to get some respite, and then, maybe again in the evening. So it can be used multiple times a day. It is not covered by insurance in my experience, so people pay out of pocket, and I believe it's about $3,000 per device. So the company does sometimes help with that a little bit, I believe, but it's something that people have to pay on their own. And like I said, it gives you kind of just a couple of hours. You can use it multiple times a day, and can give people respite for a little bit.
Thank you both. We're running over just a few minutes here, but I'm going to get to this last questions. And I think Dr. Langevin, you answered it and showed us that nice video in your presentation, but it just asks about your experience, or does DBS help with those balance issues of PD and other non-tremor symptoms? And how can you expand on that a little bit more?
Yeah, absolutely. So, gait freezing and gait balances are, a complex issue because oftentimes it's multifactorial as what's preventing the patients from having a good balance or proper gait. And so it sort of depends on specifics, right? So if we think that the freezing is related to slowness of movement or rigidity, then certainly the DBS can help out. But on other instances, there's not going to be much improvement, and people have tried different programming parameters around that with marginal benefits. It's sort of one limitation that we have now. I'd say that probably one good rule of thumb, to be safe and to help predict and moderate the expectation, is if the medication has not improved that much the symptom that you're concerned about, especially in terms of gait, it's actually unlikely that DBS is going to make a big improvement over what you've achieved with proper medical therapy. So as long as you have been treated with a movement disorder neurologist and you have tried a good number of medications to treat a certain symptom, if you haven't seen that much improvement, it's unlikely that the DBS will make big headways. And the exceptions to that would be tremor control and dyskinesia control. So like those extra movements where DBS can go over what has been achieved with medication. But in terms of these other symptoms like freezing of gait and difficulty with balance, it's really predicted by the benefits of meds.
That's great. Thank you. Thank you, Dr. Langevin. It's 11:06, so we've run over just a little bit here. I want to just take a few minutes, and I like to thank Dr. Diaz, thank Dr. Langevin for your time this morning and sharing with us your expertise. I had a couple questions about how do I get in contact with both of you. And so I want to also give you the number. You can contact both of them through also our Providence Patient Engagement Center. That number is 1-888-HEALING or 1-888-432-5787.
5464. We can type it up in the chat box right there for you, but it's 1-888-432-5464 so that we can get you in contact with either Dr. Langevin or Dr. Diaz or both of them. I also wanted to let our attendees know that we will be sending you a recording of this presentation to the emails that you have attached with your registration. So expect to see that in your inbox, and we'll have it posted on social media, so on our Facebook page. So thank you all. Thank you very much for your time this morning. Thank you to the many attendees that took their time out of this morning to spend with us to learn about Parkinson's disease and the things we're doing here at Providence and with Pacific Neuroscience Institute on the treatment of Parkinson's disease and essential tremor. Thank you very much.